Welcome back. Today we are going to discuss about the most confusing and important topic which every medical student and doctor must know, that is cardiac arrhythmia. A cardiac arrhythmia is defined as a disturbance of the electrical rhythm of the heart. Tachyarrhythmias are encountered in both inpatient and outpatient settings. Recognition and stepwise analysis of this rhythm facilitate appropriate management. Clinical decision making is guided by patient symptoms and signs of hemodynamic stability. There are many types of cardiac arrhythmia as discussed in this section. However, a heart rate of more than 100 per minute is tachycardia and heart rate of less than 60 per minute is bradycardia. That's a basic concept. So classification broadly classified into following based on width of QRS complex on the ECG. The narrow complex tachyarrhythmia, in which the QRS complex is less than 120 milliseconds, in this the arrhythmia originates within the atria and rapidly activates the ventricle via His-Perkins system. Whereas in wide complex tachyarrhythmia, in which the QRS complex is more than 120 milliseconds, in this arrhythmia originates within the ventricle and does not depend on His-Perkins system. However, sometimes it may be originates in the atria and travels to the ventricle either via an abnormal His-Perkins system or through an accessory pathway. Physical examination of cardiac arrhythmia. If the patient is clinically stable, then physical examination should focus on determining the underlying cardiovascular abnormalities that may make a certain rhythms more or less likely. Signs of congestive heart failure, including elevated jugular venous pressure, pulmonary rales, peripheral edema, and S3 gallop, make the diagnosis of malignant ventricular arrhythmia more likely. If arrhythmia is sustained, special considerations during physical examination include palpation of pulse to assess for rate and regularity. If the rhythm is irregular and rate is approximately 150 beats per minute, then suspect atrial flutter. And if the pulse is irregular with no pattern, then suspect atrial fibrillation. Again, in atrial flutter, the rhythm is irregular and rate is same, whereas in atrial fibrillation, the pulse is irregular with no pattern. Irregular pulse with discernible pattern, just second degree heart block. Discernible patterns means group beating. General principles. Supraventricular tachycardias are often recurrent and rarely persistent and can result in visit to emergency departments and primary care physician offices. Always begin with prompt assessment of hemodynamic stability and clinical status of patient. Diagnostic and therapeutic discussion that follows is aimed at hemodynamically stable patient. If patient is clinically unstable based on signs and symptoms, immediately proceed to cardioversion as per ACLS guidelines. Key arrhythmias that require atrial or AV nodal tissue or both for their initiation and maintenance are termed as supraventricular tachycardia. The QRS complex in most of the supraventricular tachycardia is narrow QRS, that is less than 120 milliseconds. SVT can present as a wide complex tachycardia if they are aberrantly conducted. SVT are initially classified by ECG to help understand likely underlying arrhythmia. Supraventricular tachycardia, that is SVT. In this, arrhythmia originates from above the AV node from atrial origin or AV junctional origin, includes atrial fibrillation, atrial flutter, atrial tachycardia, atrial premature complexes, and atrioventricular nodal reentrant tachycardia, that is AVNRT. Atrioventricular reentrant tachycardia, that is AVRT, and AV junctional extrasystoles. Whereas ventricular tachycardia, the origin of arrhythmia is below the AV node. It includes ventricular fibrillation, ventricular premature beats, and ventricular tachycardia, sustained or non-sustained. Here is diagnostic approach to tachyarrhythmia. Let's go step by step. First, check for heart rate. If heart rate is more than 100 per minute, then look for QRS complexes. QRS duration is less than 120 milliseconds, that is narrow complexes, then it may be supraventricular tachycardia or atrial origin. And if QRS complexes are wide, then it may be ventricular origin or SVT with aberrant conduction. First, narrow complex tachycardia, that is QRS duration which is less than 120 milliseconds. Next, check the rhythm, that is look for P waves. If P waves are not present, then immediately start vagal maneuvers or IV adenosine. If tachycardia terminates after vagal maneuvers or IV adenosine, then it may be SVT. And if it does not terminate even after vagal maneuvers or IV adenosine, then there may be atrial flutter. Next, if rhythm is regular, that is there are regular P waves, then check for RP interval. The RP interval is the time from onset of QRS complex, that is ventricular activation, to the end of P wave, that is atrial repolarization on the ECG. If RP interval is short, then there is possibility of typical atrioventricular nodal reentrant tachycardia, orthodromic AVRT, sinus tachycardia and junctional tachycardia. And if RP interval is long, then there is possibility of inappropriate sinus tachycardia, sinoatrial nodal reentrant tachycardia and ectopic atrial tachycardia. Next, go for wide complex tachycardia, that is QRS duration which is more than 120 milliseconds. If the rhythm is regular, then there may be possibility of ventricular tachycardia and SVT with aberrant conduction, that is bundle branch block pattern. And if rhythm is irregular, then there may be possibility of atrial fibrillation with aberrancy, atrial fibrillation with Wolff-Parkinson-White syndrome and polymorphic ventricular tachycardia. So this is all introduction to cardiac arrhythmia. The more detailed study of each cardiac arrhythmia we are going to do in next video. Stay tuned, stay updated. Subscribe my channel for more such content.